who's with me? Sorry, what's your name?
دكتور يزيد المعشوق دكتور F2 from military hospital دكتور.
Dr. Yazid?
اي نعم.
Okay, Dr. Yazid, go ahead.
48-year-old male veteran present to the emergency department with tearing chest and back pain. He has a history of hyperlipidemia and a family history of coronary artery disease. He is identified to have an aortic dissection that originates in the ascending aorta and extends into the common iliac artery on the right. He undergoes an emergent ascending aortic repair with hemi-arch. Post-operatively, he developed worsening renal function and abdominal pain with lactate of 7.6. The aorta just distal to the left subclavian artery has a true lumen and false lumen with diameter of 38 millimeter. Which of the following statement is true regarding the aortic dissection? So A,
Okay,
using...
before, no, just time, before we start, let's talk a bit about this case, So this patient, he came with a type A dissection, correct?
Correct.
And they fixed it.
Yes.
And then later on, postoperatively, he developed worsening renal function and abdominal pain. It was lactic 7.6. What does that
Correct.
mean? What does that mean when you have renal function and abdominal pain and lactic went up?
Most likely had malperfusion to the kidney or to the bowel. Yeah.
All right, that's good. So what now? Do we still call it asymptomatic or this is symptomatic?
No, this is symptomatic, definitely.
Or complicated. They call it complicated.
Yes.
This is a complicated or uncomplicated?
No, this is complicated.
Okay. You see, they confused. They gave you the diameter 38 millimeter, correct?
Yes.
Usually we don't fix it until what the diameter we fix it. Should be at least 40, correct?
Correct.
So if you look at the 38, maybe you get confused, say, oh, we don't need to repair because 38. But now this is for uncomplicated. When it's complicated, then the size doesn't matter. Okay. So this sentence is confusing for you, but they put it just to, confuse you. So here it doesn't matter what the lumen, as far as a symptom become complicated, we have to be fixed. Okay.
Okay.
So we have type A already fixed, and postoperatively, before he was fine, just chest pain, right? There was no renal dysfunction, was no abdominal pain. So before surgery, he was fine. Only type A dissection because he came only with a chest pain and back pain. But later on, after they fix it, he has a renal function. Now become a complicated,
Yes.
Okay, so let's now see what they're saying now. Let's say first one.
A, using the new SVC and SCC reporting standards, the patient should be classified as a type B07.
Okay, let's stop on this one. Do you know what this reporting standard? You know how they report this one?
Yeah, this is a landing zone in the aorta.
Correct. The first number is proximal.
Yes.
And the second number is a distal, correct?
Yes, correct.
All right. So 0, it means where? It means ascending aorta, correct?
Yes, correct.
So even without knowing it is 7 correct or not, this is mean wrong because you cannot have 0 with B. Because the moment it's 0, the tear starts in 0. That means an ascending aorta. So it should be type A, correct?
Yes, correct.
So this is wrong just by looking at that. I don't know about number 7. Number 7, you have to look at the level, okay?
Yes,
but the moment I saw 0 and B, I knew this is wrong.
Yes.
You see?
Yes, correct.
All right. So let's go again. Before we go, let's go and look at that. So people can refresh their mind. This is the new classification. This is called the SVS classification, correct?
Correct.
So this is the zone. So we have two numbers. The first number is the tear, entry tear, and the distal one where is the extension. So the 0, 1, 2, 3, 4, 5, 6 is 6 is what? 2, 3, 4, 5, 6 celiac, 7 is SMA, 8 renal, 9, 10, 11. Okay?
Yes.
So in this one, it's not 0 for sure.
Okay.
This is subclavian, so it should be 3. I'm going all the way to the iliac, so it should be 10.
10, right? Correct.
Okay. But again, without me knowing that, the moment I saw B and 0, I knew it's wrong. So this is very easy, even if you don't memorize all these numbers.
Yes,
but
correct.
I think it's better to memorize it because you may get questions. So you need to memorize these numbers now.
Sure. Sure.
Okay. All right. Let's go back. So first one is wrong. Let's go to the next question.
B, the patient should have initially had an elephant trunk with thoracic endovascular aortic repair, TFAR, for the descending aorta. I think this is
All
wrong
right.
because his symptoms was only in the chest, and the life-threatening is the ascending, so it should be fixed first.
But why just do an elephant trunk? It's not, I mean, for the futures.
Yes.
So you don't think it's better just to all the time do elephant trunk?
No.
Let's explain what's different between ascending and elephant trunk. Do you know what's different? See, when you have a type E dissection, you just go there, you know, they clamp the aorta just distal to innominate artery. They stop the heart, they do perfusion flow through the femoral, and then they replace only the ascending aorta. Okay?
Okay.
They don't touch the arch, they don't touch anything.
Okay.
This is very quick. It can be done quick. You don't have to do deep hypothermia or cardiac arrest, you know, just like you're doing a cabbage, you know.
Okay.
If you have to do an elephant trunk, then you have to replace the whole arch.
Yes.
Then you have to do a deep hypothermia cardiac arrest. Then you have to cool the patient, you know, to like 20 degree. Okay, so you have to cool the patients, and this has high mortality, morbidity. You know, it takes a long time, so it's not good for emergency cases. You know, unless if you're planning ahead of time to go distal, then you do an elephant trunk. You know, so elephant trunk, yes, is better, but takes longer, and it's not good for emergency. The reason why you see an emergency, it's like any like if you have a rupture aneurysm, infrarenal aortic aneurysm, rarely we do a bifurcated graft. Always put a tube graft, even if the iliac arch disease, because in the rupture, you want to get the patient life off the table. Patient already sick, they already ruptured, they already hypotensive. Your primary tension is get the patient alive off the table. So you want to do the minimum. You don't want to do the perfect procedure. You do the minimum procedures. So patient with the rupture infrarenal, just put a tube graft and then get out. Even if the iliac has been dilated, unless if you have like a huge iliac aneurysm, it's a different story. But we don't do like aorto bifim for rupture aneurysm, and you know, so most of the time just tube graft. And the same thing here, when you have a type A dissection, the most of the time they just do an ascending, very quick, in and out. Okay, so this is the other reason. So this patient, if patient came with a renal dysfunction, abdominal pain from the beginning, I would do elephant trunk because I know I'm going to put a TVAR after that, you know. But he did not. He come only with a chest pain. So this is the reason. Okay. All right. Let's go next.
C, the hemi-arch repair is preferred over the frozen elephant trunk in this setting.
Yeah. Again, I mean, hemi-arch repair, frozen trunk is better because in hemi-arch, if you repair it, you still cannot put. There's no landing zone for TVAR.
Okay.
Frozen elephant trunk is hemi-arch plus it has like an elephant trunk, so you can do a TVAR. So anytime you have a dissection and you're going to go to the arch, so it's better to use an elephant trunk because you already went to the arch.
Okay.
You know, it's different from the first scenario. So if you go to the arch, it's better not to just repair the arch. Go repair arch and do frozen trunk. So always frozen trunk is better than hemi-arch. Okay?
Okay. Treatment of the dissection is contraindicated with the recent type A repair.
Like they said, but you see, this is if you have uncomplicated.
Yeah.
But never have complicated, right? So it doesn't matter if you have type A dissection. So you don't have legacy to wait.
Yes.
You know, if it's uncomplicated, yes, it's better. He just came out from surgery. You don't take him back for another surgery. But here he had a bowel ischemia. You cannot wait. Lactic 7.6.
Yes.
So then you don't care. It's not a contraindicated if you have a symptom. If you don't have a symptoms, patient just has dilated like type A, like some aneurysma dilatations, then yes, it's not the best time. You have to wait at least like 2 weeks until you get off the acute stage. But patient like, you know, with the bowel ischemia or renal dysfunction, you don't have this time. You have to do it as soon as possible. Okay?
Yes.
All right. The last one.
The patient should undergo TFAR.
Okay. What do you think?
Correct, but it can be done with this. Only we did an hemi-arch repair. Can we do the TFAR?
Yes, because now, you see, now is they tell you what the tear. Let me see if this is what the tear is.
And the ascending
That's not
aorta,
sure.
and extended to the common iliac.
Yeah, but you see, but what they want, this is not a good question. They said TVAR, but they didn't tell you where's the landing zone. You may land it all the way in the, it depends how where the tear is.
Yes.
You may do like extra-anatomical bypass and you landing in zone 1 or zone 2, you know?
Yes.
So here they didn't specify because they didn't tell me it was a tear. But in general, yes, you have to do a TVAR anyway, you
Yes.
know, because
Yes.
you need to open the lumen to get the blood flow to the bowel, okay?
Yes. Yes.
So always when you have a bowel ischemia, the first thing you fix the primary tear.
Okay.
It's about 80% is enough, but 20% is not enough. You have to do extra.
Okay.
So what happened when I do this one, because you want to depressurize the false lumen and direct blood to the true lumen. So you do a TVAR, and after you do a TVAR, what you do? What you have to do? You have an angiogram to see if it's renal open or bowel is open, right? Because
Yes.
even if you do a
Correct.
TVAR, maybe the renal is still occluded. Maybe the SMA is still occluded.
Yeah,
Because
you
again,
might
not
need
all
to
the time
extend.
will open. So
Yes.
the first thing I put a TVAR and then an angiogram. I will look. If I see the true lumen is open and renal now reperfused, SMA is open now, then that's it. I stop. Okay.
Okay.
Let's say they are not open. What options we have? We have like 4 options to deal with that. If it's like you do a TVAR and still the lumen is not open, you still don't see SMA, you don't see the renal.
Yeah, you might do chimney to open the renal.
No,
And
no, simple. I'll first start with the simple, okay? The
yeah,
first, the true lumen still collapsed, right? So you
yes.
can put uncovered stent called a dissection stent, you know? You know about it called bare metal
But
dissecting stent. It's from Cook.
yeah,
This will open the true lumen.
this is Doctor the one they call it Petticoat technique or
لا, البيتيكوت is different. No, Petticoat
okay.
is for the false lumen. This is an uncovered stent. You put it inside. You put a TVAR, and they put uncovered because it's uncovered stent. You can put it through the SMA, celiac, and renal. So this will open a true lumen. Because after, even if you put a TVAR, sometimes true lumen still collapse.
Okay.
All right. So either you can do this one, and this will open the true lumen, and then we'll see if it's open or not. Or you can do what's called stabilized technique. Stabilized technique, you put a balloon and you inflate it, but you don't inflate to the size of the aorta, not more than that, because it could rupture, you know?
Okay.
Called the
Okay.
stabilized technique. The third option, you do that and still no flow, then you cannulate and put a stent.
Okay.
Okay. The last option, if the renal or SMA coming from the false lumen and you put a TVAR and still no flow, then you what you do? You do fenestration. You fenestrate it. So you open the septum between true and false lumen, then the pressure will equalize and this will open.
Okay.
So what I'm trying to say is a lot of technique, but first thing you start the TVAR and do an angiogram, and then you decide, do I need to do anything else or not, you know?
Oh, okay.
If it doesn't open, the next step is to do a bare metal dissection stent. If it doesn't work, then I cannulate the renal arteries and put a stent. If it doesn't work or I cannot cannulate, then I do fenestration. This is the step 1, 2, 3, 4.
Oh, okay. Thank you.
Let's say you do all the things doesn't work, then I may do like debranch, open the belly and do like debranching, you know, because you have to get the ball to the renal SMA. You have to find a way to do it.
Sure.
But luckily from our experience, 95% the moment you put stent in the TVAR, everything will open down.
Okay.
The good things.
Okay.
All right. Any question? And Ali, if you have to add anything, please, guys, feel free to add anything.
No, also right.
Dr. Samer,
Any question? Yes.
since it was a type A from يعطيك العافية أول شيء. Since it was a type A, they fixed the entry tear. المفروض malperfusion, is it expected really after closure of the entry tear?
No. But this is a problem with the dissection. You don't know how do they behave. Every patient behave differently because every dissection is different. So this is a problem with dissection. You cannot predict what could happen after. That is why completion angiogram is very important. Like sometimes maybe renal is open, and the moment you put a TVAR, they occluded because they are coming blood flow from the false lumen, and you debrachalize the false lumen, then you see the renal is closed. So anytime I do, not the type A, type B, I'm talking. Type A, no, I think the moment you change that ascending is enough. But
this is
like,
the question.
if I'm
Is it
doing
type
type
A?
B, yeah, this type A. But for some reason he developed. Maybe after they fix it, you know. Remember, you know, when they do, I don't know if you see an open, how they fix the type A dissection. The distal above the annula, aortic annula, they suture it. Distal, they open to the two lumen because you still have two lumen there. And we're not taking off, the dissection is still there. So they suture the graft to the two lumen. So they suture the adventitia. So after the after type A dissection, you still have flow to the true and false lumen. You get my point?
Okay.
So maybe after they did it, now you have more flow to the false than the true. Maybe before was the more flow to the true than the false. But when you open to the both, now you may have a false getting more blood than the true. That is why they get these problems.
Makes sense.
Because when you do dissection, always when you do surgery for dissection, distally, always you're going to see a dissection because you can dissection always go all the way to the iliac and you replace only the descending aorta or the arch or ascending. So always distally, when you open the aorta, you're going to find the dissection and the lumen. So you cut some of this septum, just small piece, and you suture the adventitia. So at the end, you are really flowing the blood to the ascending, to the both lumen. Because the whole idea is to repair the proximal, not the distal. Distal, you need more workup later on. I hope you understand what I'm saying.
Yeah, I understood. Thank you.
Okay, so it's the reason why I'm saying after repair, you don't know how things will behave. So you have to watch this patient. You see, with open, you cannot do an angiogram because patient is open and ascending aorta and, you know, pump and everything. But when you do a TEVAR, I'll do an angiogram. But in ascending, they don't. They just do and replace the aorta and just go and look. If something happened, they bring patient back like this case. Okay.
دكتور سامر
Yes.
مساء الخير يا دكتور. دكتور, how we will do
Yeah,
fenestration? Endovascular ولا you will open the patient?
No, it's endovascular. It's easier. It's endovascular. But this is the last option because what happened with the fenestration, you may collapse the whole intima, collapse and cause a distal occlusion because you get like a wire through and through, and it's like a cheese cutting. You cut it from both sides, you know, and you pull it down. So sometimes you have herniation of the intima to the one of the iliac and cause acute occlusion. So really, it's not a good technique unless, you know, unless if you like a small hole and you open. But if you're going to cut the whole septum, you have to be careful after you do angiogram. Be sure you don't include any of the iliac. If this happened, then you have to put a stent. So fenestration is your last option. It's not first option. The first option, the most common, to use a bare metal dissection stent. This is the most common. Then stent the orphic of the renal or SMA. If it doesn't work, then you think about fenestration. This is how to go 1, 2, 3. All right. Any other question?
Yes, Dr. Samer, if you have patient who's having type A dissection and his initial presentation is bowel ischemia,
Good.
will you
We
start
have a
with type
question
A?
later on coming. We have a question later on come. We can talk about it now. It doesn't matter. What do you think we should do?
I think we should fix the type A first, and at the same time we can do TEVAR for him.
Same time do TEVAR. Okay.
I'm not sure, but
How long
this is
does
only
it
my
take? How
thinking.
long does it take the bowel to go dead after you occlude it? How many hours?
Many.
Like about 6 hours, more than 6 hours? If you could SMA, how many hours? Maximum you have 6 hours. After that, the bowel will be dead,
Yeah.
correct?
Yes.
So you have to do, when the patient can bowel ischemia, 6 hours is the maximum, you know, if it's completely occluded, correct? And when you have a bowel ischemia, this is a dead person, okay? Type A dissection is an emergency, but it's not very urgent. It's a controversial, so I have to evaluate the patient. If patient is stable, type A dissection, but he has like really severe abdominal pain, lactic acid is too high, I may have to do the abdomen first, you know? Either do a TEVAR first, or you open it, or whatever you have to fix it. I'll concentrate on the, and then I'll take him to the type, because type A takes about 4 or 5 hours, and after that to do the bowel. I mean, you can do it. So it depends how situation, how high is the lactic, how you're suspicious. So you have to decide which priorities. But this is the only exception where sometimes you start with the distal before the ascending, because bowel ischemia is the leg ischemia is not an issue. Leg is not a problem. Renal is an issue, but it's not very important because even if renal went away, if we went to renal failure, you can do dialysis. So even if renal, worse renal, I'll do the ascending first because ascending is more important. Because even if the renal went down, he will not die. He will go to dialysis. But bowel ischemia, he will die. You see, this is different. So why I should spend like 6 hours fixing the ascending and then have a dead person because of the bowel ischemia? So the bowel ischemia is the only one we may think to fix it before you go with ascending. So you have to decide at that time which one is priority, depending on the patient condition, if he's stable, unstable, how is lactic acid, how high suspicious of bowel ischemia, is it like only part of the bowel or the whole bowel? So really, it's it's a decision you have to make it at that time. All right.
Thank you, doctor.
No problem. You want to take it? Vara, you are with us. Let's go.
Yes.
Let me see which next one. Oh, this one. Where is it? 19, this one. Okay.
A 67-year-old man present with acute onset of chest and back pain that he describes as a tearing pain. He is promptly diagnosed with an acute type B dissection with an entry tears just distal to the left subclavian artery and termination of the dissection in the infrarenal aorta. Which of the following is true?
So just type B dissection, straightforward. So let's see what their question, what they're asking for.
Chest pain is the most common presenting symptoms of type B dissections.
Okay, so type B dissection, either they come chest or back pain, correct? This is,
Yes.
we have type A and type B, correct? Type A
Yes.
is most common, they come back or chest, type A.
They come with
Type
the
A,
chest type A with chest pain.
Correct. It's most commonly is chest pain because it's the front and close to the heart, where type B is more the back because you see, aorta is anterior, then go to the posterior, correct? If you see the anatomy, it's anterior and then go all the way back into the posterior. So most of the time they come with a chest pain for type A and type B is a back pain, but doesn't mean that you can have them both. But I'm saying what the most common. You see, I mean, type B can come with a chest pain, and again, type A can come with a back pain. But usually most common for type A is the chest and for type B is the back. Okay?
Yes.
All right, let's
Mortality
go next one.
mortality rates are higher in patients with lower extremity pulse deficit.
Right. So we talk about it. See, if you have lower extremity deficit, no flow to the legs, it's not a patient will not die from that, correct? He may have an ischemia, may get like compartment syndrome, but nobody will die. It's different from the bowel. If they put the bowel here, I would say yes. But legs is not an issue because legs take ischemia for hours and hours, So I don't think it'd be an issue. So patient came with lower extremity pulse deficit, it doesn't make huge difference mortality because after you fix it, most of the time they come back. And again, leg tolerate ischemia very well, so it's not an issue. But this bowel is different. So if they put a bowel, I would say yes. But because they put a lower extremity, I would say no. Renal maybe also yes, because renal failure, the end of the renal failure increase your mortality. So, but with lower extremity, I don't think so.
Yes.
Okay.
CT angiography is the most common imaging modality for diagnosis of type B dissection. I think this one is
Okay,
correct.
Correct, yeah. That's what we do all the time. Okay.
Aneurysmal degeneration occurs in approximately 10% of patients with acute type B dissection.
You
I think
it's
it's
a
more
high
than
or
10%.
low?
No, it is more than 10%. Yeah.
Correct. Why is that? Because the reason why uncomplicated even time we do them, because we know the majority, even uncomplicated, will develop an aneurysm later on. Correct?
Yes.
So the reason why, we try to fix them for remodeling. So the majority of patients, even uncomplicated, develop aneurysm in the future. Okay. The reason why some people they think, okay, let's fix them now early before they get to aneurysm. All right, next one.
Mortality rates are higher in patients treated surgically versus those managed medically.
Okay, so type A dissection, correct? Type A is uncomplicated. Sorry, type B. This is type B dissection.
B.
Sorry, type B dissection, uncomplicated. Do we treat it surgically or medically?
No, medically.
Okay, why is that? Because they found surgery and medical the same. That's why they decide to do medically first. Unless it become complicated, then you have to do something. But as far as uncomplicated, type B dissection, medical management, same as surgery. So they said, why should do surgery? The reason why we treat them medically.
Mhm.
You get the answer?
I get the answer, but still the option here is not clear. Mortality rates are higher in patient treated surgically versus those managed medically. That's mean they died from the complication because they are complicated type B dissection.
No. They said you have a type B dissection patient, okay? And you decide to treat it surgically, and some of them you try to say medically. Okay, which one has high mortality?
You mean both group are asymptomatic? Both group are
Asymptomatic.
non-complicated.
Uncomplicated, yeah.
Yeah, most likely those
uncomplicated.
with surgical intervention they will have the mortality. Yes.
Because they have more surgical,
Yes.
higher mortality.
Yes.
Is statistically significant? We're not talking about 30 days mortality. We're talking about long-term mortality. Because they didn't say mortality, you know. Like if you follow up then like for 3 to 5 years, and patient treated with a surgery versus treated with a medical. They found that surgical is a little bit higher, but it's not statistically significant. It's a trial. It's not like it's no explanation. Like I give like a carotid, if less than 70%. Okay, if you do a surgery or do medical, the same like stroke rate, you know. So sometimes things doesn't make sense. The reason why we do a trial, as I said before, in medicine, not everything make a sense because everything's make a sense. We should do a trial. Like if you look at this way, of course, obvious surgical people have more mortality, then nobody will do any trial because we use a sense. But in medicine, common sense doesn't work. You have to go with, and many times trials prove that we are wrong. Like remember we talked today about doing carotid under regional anesthesia versus general anesthesia. By logic, you think regional anesthesia have less mortality than general anesthesia for carotid. But the trial shows no difference between regional and general anesthesia for mortality after carotid.
Yes.
So the same things here, even though it sounds, yes, surgical is higher, but unfortunately the trial which has been done to compare these two groups, they found that surgical group a bit higher, but not statistically significant. So we can see it's no different. Okay.
Okay, clear, yes.
Yeah. Okay. Any question? Or anybody want to add anything, please guys, feel free.
دكتور سامر نفس المشكلة هذه
Yes.
دائما نتناقش فيها أن best medical treatment versus TVAR according to instead XL trial. نعرف أن mortality is insignificant in the short in 1 year almost the same. يمكن less حتى في TVAR group 5 years نفس الشيء. بس إنه we still answer the questions as best medical treatment is the treatment of choice.
Correct. And the mortality, as far they did not say it's a 30 days mortality, they took most of the time take a long-term mortality. Like, I mean, surgical group, they may have a longer, or more mortality in 30 days, but on the long run, they will catch up with the medical. You see, medical group will have less mortality, but later on will have more mortality. So they will balance each other, So this is what happens. So when you talk about mortality rate, most of it talk about 3 to 5 years. Let's say 30 days mortality, then I would think surgical group will be higher mortality than medical group. Any other question? All right, let's keep going. Wow, running late. Who's there? Yahya, want to take this question, Yahya?
Yes, Dr. Samer.
Yeah, please.
86 years old, farmer present in extremes with abdominal pain, hypertension, and back pain. On arrival to the hospital, blood pressure 65 over 32, and bedside ultrasound confirmed 6.8 centimeter abdominal aortic aneurysm, which the following is true. This patient,
Okay.
86, confirmed abdominal aortic aneurysm, hypotensive.
So his rupture aortic aneurysm with low pressure, 65 over 30. So what do you think is his mortality? Or let's say less
More
or more
than
than
60.
50. Huh?
Around 60%. 2
Yeah,
seconds.
it's more about 80%, 70 to 80%, but more than 50 for sure. So if you don't the answer exactly, but you know more than 50, so you know this is wrong. Because usually it's high, it's about 70 to 80% rupture aortic aneurysm, especially when they come with a hypotension. Okay,
Okay.
so this is wrong. Next one.
The incidence of rupture AAA has increased in last 40 years.
You think so? Because now we're doing more
Yeah.
EVA, correct?
Yes.
And now we do a lot of early detection, we do a lot of CAT scan. So really the incidence is coming down because now we do a lot of surveillance, with a lot of CAT scan. We are very liberal with EVAR. So really we're seeing less and less of rupture aneurysm because we have become more aggressive with the treatment because it's easier, more patient-rated EVAR. They will not exclude before because they are old. Now we do them under local anesthesia. So we're repairing really more aneurysm now than before. So this is the reason why the risk of rupture or the rupture AAA, we see it less and less. Okay.
Okay.
Next one.
The improvement in endovascular technique have not influenced the mortality rate for rupture AAA.
Well, let's do it this way. If you do a rupture AAA, do endovascular versus open, which one has less mortality?
Endo.
Endo. Yes, and this is proof. You know, this has been improved trial that if you do rupture aneurysm, the reason why the guideline now for rupture aneurysm first line is endo, not open, because they found that endovascular have less mortality than for rupture, not for selective. Selective, it doesn't make a difference in long-term survival. But in rupture, they found that after 3 years, first 2 years, no different. After 3 years was a difference between endo and open. And this is an improved trial, okay? Next one.
The rapid and aggressive resuscitation in preparation for repair of rupture AAA improved survival rate. Wrong.
When patient, why?
Patient rupture, better to keep him in normotensive.
Okay, permissive hypo, even not normal, hypotensive, right? Called presumptive hypotension, right? So you want to
Yes.
keep it special low, not even normal, like 100 is high, maybe like around 80, 90. You know, you don't want like 120, but normal patient 120 is too high for rupture. They have to keep him hypotensive. So you don't want to be aggressive. The reason why when you go to the ER, they don't know, ER physician will give fluid volume, say, no, cool down, keep him pressure low, because this will increase his, risk of rupture if you have a contained rupture. Next one.
Smoking cessation is the most effective non-surgical intervention to reduce the risk aneurysm-related death.
I'm sure the only one left correct?
Sure.
Yeah, this is very for true. All the studies, everyone is very important. They found that if you stop smoking, increase the rate of aneurysm expanding and even ruptures. So this is the only non-surgical intervention they was proved by a trial. The reason why it's very important people with aneurysm to ask them to stop smoking, because they found this smoking cause rapid expansion of the aneurysm and increase the risk of the ruptures. Okay.
Okay, Dr.
You know what medication can cause decrease size of the aneurysm?
I don't know.
Metformin. I mean, it's not approved yet. We don't have like level A evidence, but a lot of trials, they showed metformin is an excellent medication, really. This is the reason why we thought that people's diabetes, like in Saudi, where you don't see many aneurysm, because we thought that diabetes protect against aneurysm because of the calcification. But really, new studies show that metformin is really the one who decrease the inflammation, because aneurysm, the pathology of the aneurysm formation is inflammation first, and then the wall become weak, and then the aorta become dilated. So they found metformin has anti-inflammatory effect and prevent growth of the aneurysm and even cause it to shrink. They're still doing a lot of study. Maybe in the future we're going to prescribe metformin. So the reason why in diabetic people we see less aneurysm, not because of the diabetes itself, because they're using metformin. And metformin is very common medication in diabetes. So put this one in your mind if you have it in your exam or read it somewhere. Okay.
Okay, Dr. Samer.
Any questions? Because we go, or any comment from anyone to add anything or question? All right, so let's go next one. Abdullah, you want to take this one, Abdullah?
Doctor,
Yeah, which one? Go ahead.
a 65-year-old man with a history of tobacco abuse, hypertension, and chronic obstructive pulmonary disease. Present with abdominal pain, hypotension, and pulsatile abdominal mass. He undergoes urgent evaluation with a bedside duplex, which confirm an abdominal aortic aneurysm. A CT scan angiography is then performed for further evaluation. He is slightly hypotensive. Which of the following is true regarding a rupture AAA?
Okay, so
pain-
he's ruptured AAA,
Okay.
and he's at the slight hypotensive, so he's kind of stable patient, correct?
Yeah,
Slightly
he's on a
hypotensive. Yeah.
hypotensive.
Okay. Angiogram
A,
is then performed for further evaluation. Okay, go ahead.
A, pain can often radiate to the testis and inguinal canal, usually to the back and flank.
Okay.
B, hip pain is an infrequent symptoms. It could be. C, the classic symptoms of hypotension, abdominal pain, and pulsatile mass are present in 60 of patients. I think less than that.
Okay.
A new onset loud mechanical-like breathing is common with an aortoduodenal fistula.
Okay.
E, rupture abdominal aortic aneurysm is misdiagnosed in 50% of patients.
Okay. Well, let's go through each one by one first, okay?
Okay.
Remember when I said, when you do an aneurysm, you know, I don't know if you remember, you had guys around with me many times. When you come next, when you do abdominal aneurysm repair, open, not endo, okay?
Yeah.
Or patient comes rupture. I told you next step, you can look at his scrotum. Remember this? Did I say that, or you were not with me?
Yeah.
We always look at the scrotum. If you come and you find his scrotum is full of fluid, okay? This is very common to see after aneurysm repair. The scrotum is full of fluid or blood if he has ruptures, because retroperitoneum is connected with the scrotum fascia. So patients becomes rupture aneurysms. Then after that, the blood will go all the way down to the scrotum. So next time you see scrotum like a balloon. Or you do a surgery, next day you see scrotum is swelling up, you have to think about leaking from around the anastomosis, or you have a blood around it, because all is retroperitoneum. Okay. So what I'm saying is that scrotum and they are connected with the retroperitoneum. So when you have pain, yes, you get a back pain, but usually radiate to the scrotum and the testicle, because they are connected through the fascia and retroperitoneal space. Okay.
Okay.
So pain is, yes, often radiate to the testicle and inguinal canal. Yes, back pain is the most common, but the radiation usually radiate to the testicle and inguinal canal because of that, you know. So let's keep this one in your mind. And again, when you do aneurysm repair, always next day look at the scrotum. It's very important.
Sure.
Hip pain is infrequent symptoms. No, you can get hip pain also. It's like a back pain. It's not infrequent, but it's not the most common. The most common, as you said, back pain. So it's not infrequent symptom. Classic symptoms, you said, is 60% is too high. Usually it's less than, maybe like 20%, 30%, you know. This is the classic symptoms. When you see a loud machine-like brewing, what does this mean? A fistula, right? But not aorto-duodenal, should be a vein, right? See, to hear brewing, it should be a vein, it's aortocaval. So if you see a loud machine-like brewing, this is aortocaval fistula, not aorto-duodenal. Aorto-duodenal, you don't hear brewing, you see bleeding, right?
Yeah.
So you have to be sure what. So it's yes a fistula, but not aortoduodenal. It's aortocaval. Okay.
Yes.
Rupture AAA is misdiagnosed in 50%. No, it's less than 50%. Otherwise, most people will be died. So I think maybe 20, 30%. Okay. So I think the best answer will be A.
Yes.
All right. Any question? It's not a very good question, but it's okay. Any comment? All right, let's keep going. Let's go today. All rupture aneurysm today. Here we are. We go back to Ahmed. You want to take this one, Ahmed?
Yes, okay, Dr. Samer. 68-year-old woman presents with abdominal pain, syncope, and hypotension. She undergoes CT imaging that shows ruptured AAA. She is urgently taken to the hybrid suite for repair. What factors should be considered when performing EVAR for ruptured AAA?
Okay, it's good questions. So if you decide to go with EVAR, what factors? Okay, let's go one by one.
Okay, avoidance of general anesthesia for endovascular repair is prudent. Well, it makes sense.
Yeah.
I would consider that
Why general anesthesia is not good for?
because you want. It's good actually.
General anesthesia is good.
No, I mean local anesthesia is good. General is bad because the patient will develop hypertension.
Why did develop? No, should not develop hypertension. No, not because of that.
I think
let's go to different. Patient, you take him to surgery, you go do an open repair for rupture aneurysm. And the anesthesiologist is trying to intubate the patient for general anesthesia, okay? Because you cannot do local, rupture aneurysm is the local, you do general, yeah?
yeah.
What you should tell the anesthesia?
You should tell them that I will clamp for you to hydrate the patient.
No, not listen to me.
Mm.
I'm saying you are in the OR, and this is for true. I
Okay.
mean, it's very important, guys. It's very important. This is true, and I thought you know it. Patient is ready for anesthesia. It's rupture aneurysm. You can take him to surgery. It's in the OR, the table. You're prepping the patient, and the anesthesia try to intubate him. Correct?
Okay.
What you should tell the anesthesia in this moment?
No
If you
muscle
don't tell him,
relaxant.
suddenly the patient,
No muscle relaxant.
Yes, because what they do in general anesthesia, the first thing they give muscle relaxants that they can intubate the patient. And what contain your rupture is the muscle tone. The moment you give a muscle relaxant, it's going to rupture in front of you. Suddenly, patient become hypotensive, not because of the anesthesia, because he becomes from contained to free rupture. So when I do that, the first thing tell the anesthesia, be careful, please. Don't give. You have to intubate without muscle relaxant. It will be difficult, but they have to do it. Or if you have to give muscle relaxant, then I tell him wait. You prep the abdomen, everything, and the knife in your hand. And then you tell him, go and start now anesthesia. Try to intubate him now and give muscle relaxant. But if the patient is still on the table, you did not prep the patient. You know, your table is not ready yet. And he starts general anesthesia. You didn't even put the Foley. And suddenly patient collapsed in a big problem. So again, so you have two options. One option to tell the anesthesia, don't give muscle relaxant, intubate without muscle relaxant. If he said, I cannot, he said, okay, stop. Prep the patient, prep your table, be ready to open. You have a knife in your hand. I'll tell him now, give it. And then you're ready. If something hypertensive, you open like in 2 seconds and you clamp the aorta. Okay? It's very, very important, this step, guys. Next.
Femoral cut down is preferred to percutaneous access due to initial avoidance of heparin. No, we usually do them percutaneously faster.
What about heparin
heparin
in rupture aneurysm? This is, you see, guys, this is all practical point. You have to know.
No, we
Because, like,
heparinize in rupture after sealing.
what do you mean by sealing?
When we deploy the main device at the rupture point, or the whole device, then we can heparinize.
Okay. This depends what you're going to do, you know? If you're planning to do like aortic balloon, I will put aortic. The moment I put aortic balloon, the moment I get control, then I give a heparin. Okay. Is the risk of thrombosis. So it depends. If you think patient you can give low dose heparin, or wait until you put your balloon, and then after you inflate your suprarenal aortic balloon, then you give a heparin. Or wait until you get the seal as you do with an EVAR, and then you give a heparin. But don't give heparin ahead of time until you have a kind of control. I agree with that. Okay. Next one.
C. Use of EVAR decrease the risk of abdominal compartment syndrome. I think they are the same. No difference in between both techniques.
No. Well, which one you have more compartment? If you do an open or EVAR?
I believe open, you decompress the peritoneum.
Yeah, because about decompress already, evacuate the hematoma. It's the most important, you know. So really you see less compartment with the open, but with the EVAR, yes, you see it, but the hematoma is still there, huge hematoma. So it may cause compartment, you know. So at EVAR will not decrease risk of abdominal compartment lax. And I think if you have more compartment syndrome after EVAR than open repair. And how we make a diagnosis of compartment syndrome?
Blood pressure
Okay, how much?
more than 40
More.
with an organ dysfunction.
Okay, next one.
The inferior mesenteric artery should be coiled due to the concern of possible continued bleeding in the ruptured AAA. That's
Okay.
time consuming, and most of type 2s, they should stop by themselves.
This is yes and no, because you see rupture is different from elective repair. So elective repair type 2 is not a problem. In a rupture, it is a problem because you keep bleeding, you know. But this is not your priority. Your priority is you have no time to coil mesenteric and intercostal where patient is hypotensive. You see? So what you need is to do a EVAR and then you do a compression angiogram and then you assess. If you see really is the major one still leaking, then you have to find a way to coil. But you will not do it as primary. You don't do it first. First thing, you have to seal the aneurysm. But after aneurysm, you have to do an angiogram. If you see type 2, it depends. If you type 2 still said aneurysm, it's very mild, I will leave it. But if you find type 2 and it's still like a lot of contrast going out, then you have to treat it really. Okay. Next one.
An aortic occlusion balloon should optimally be placed in the infrarenal neck to limit renal ischemia. No, for a rupture, put it suprarenal to control the bleeding. Now, you save the patient first, then the kidneys.
Okay. In the EVAR, you know how to put intra-aortic balloon pump and how you replace it?
Yeah, I use the contralateral side, and
Okay,
then
let's
you
go step by
deflate
step.
it.
So you do what?
The first thing is you use a long sheath to push the balloon suprarenal.
Okay.
And then you ask the anesthesia to give the fluids and the blood products.
It's okay. No, give me a step. It's okay. Don't worry. But give me a step. So I want to know, the step. So you inflate it. You went to contralateral. You put the balloon, and then.
And then you go through contralateral side with your EVAR.
Okay. With an
And
EVAR.
then
Next.
with the EVAR, deploy the main body until the contralateral gate. And
Okay.
then you have to deflate the balloon and withdraw it through within the sheath. Then you pull the sheath together with the balloon and
No,
keep the
just
wire.
confuse me. So, but your wire is behind the EVAR, correct?
Yes.
So now you deflate the balloon, correct?
Yes.
And the contralateral limb still open, correct?
Contralateral open. Yes.
So what's going to happen the moment you deflate the balloon?
When you deflate the main body is deployed now already.
Right, the contralateral is still open.
Yeah, the contralateral is still open.
So you deflate the balloon, and then the blood will go. So you have
through the gate. Then
the gate.
then you have to go with another wire through the contralateral gate. Then you deploy another balloon from within. You deflate the first one.
Okay, it's called double. Let me show it to you. Okay, let me share my screen. Okay, it's an important case for practical. Okay. Okay, called the double balloon technique. You see my screen now? Do you see the double balloon, or you still see the first one?
Yes, we can see.
Yeah, we see it.
You see the balloon? Okay. So that's what exactly we do. So we go from one limb with a long sheath. As you said, Ahmed, you have to be a long sheath, because if you don't long sheath, the balloon will go down. And you inflate the balloon in the suprarenal, correct? From the other side, you put a main body. Your balloon still here is inflated, correct? But before, if you deflate it now, as Ahmed said, you're going to have a bleeding here. So now you go from ipsilateral, you go from ipsilateral, you put a second balloon here. You see it here? So you close it, now you below the renal. Then you take this one down, then you put cannulate contralateral limb, and then you finish it. Called a double balloon technique. Is it clear, guys?
Yes, clear, Dr. Samer.
Yes, clear.
I-
Doctor.
Very important, guys, because if you want to do it, this is how to do it. Because you may rupture aneurysm. Now time to go open the book and look how I do it. So go first balloon, put a TVAR, deploy it completely. Not that usually what we do. Just you have to deploy the epitheater completely. Okay, the second balloon still there. You get the second balloon. You go 3 epitheater. Very easy. Balloons. The wire is still there. You inflate infrarenal. Then you deflate this one, the first one. Then you are fine. Now you have your balloon infrarenal. So you perfuse the renal. You still have a control. Then you can use contract the limb and you finish it and you're done. All right. Any question? Oh, let's
No,
go back
thank
to
you.
the question. You're welcome. Here we go. Share. All right. So where we are now, aortic balloon should be obtained placed. Okay, that's all. So we answered it. Let's do one more question before we go. I don't know why it take too long, these questions. Let me see here. 23. Bara, you want to take this one, Bara?
Yes, please.
Go ahead.
62-year-old active man present electively to the vascular surgery clinic with 5.6 centimeter infrarenal aneurysm and 4.5 centimeter right common iliac aneurysm. He has a history of smoking and coronary artery disease. Which of the following is true regarding iliac branch endoprothesis? Ribeiro.
Okay. Okay, so this patient is 62. You have an aortic and iliac aneurysm.
Mhm.
So what you need, they want to know what the IFU for IBD or IBE, depending the vascular, you know. Guys, I think let me share this one. Also, it's an important to know is the IFU. Let me see. It's here. Yes. Do you see the screen?
Yes.
Yeah, this is very important. It's very hard to find it, you know. This is very important. The IFU for IBD, it has it cook different from GORE. It's a bit slightly different, but you have to know. Cook first, the common iliac, it has to be at least 5, the length should be more than 5 centimeters. Okay. The common iliac artery should be more than 20. This is exclusion. That's why I said less should be more. The common iliac artery should be more than 20, so accommodate the main body. External iliac artery should be more than 20. Internal iliac artery should be diameter should be more than 8. The internal iliac artery length more than 10. And the internal iliac artery diameter, as I said, between 6 to 9. GORE, it's very similar. But in the GORE, you have to measure from the renal bifurcation to the iliac bifurcation. It has to be more than 65 because the main body, they have it long, different from Cook. So in GORE, you measure from the renal to the iliac bifurcation is more than 65. In Cook, you just need the length of the common iliac artery more than 5 would be enough. And the same, the common iliac artery more than here 25, there 20. Common iliac artery more than 18. So you have to write this number. So, I mean, you just have to read about it, guys, because this is the way you decide if patient can go with that or not. Okay. Any question about this one? The second thing is that for the ischemia, let me see here. Let me share this one. Here. For the internal iliac occlusion, this is very important number guys need to memorize. Even if you do unilateral iliac occlusion, the bad claudication about 27%. Bilateral go to 32%. So even the reason why these days we try to preserve both if we can, because even unilateral can end with 27% claudication and 14% impotence. Bilateral then 18. Ischemic colitis to 3%, spinal cord ischemia less than 1%, and mortality increase if you include iliac artery, increase your mortality. So I think you have guys to memorize this number for the exam. All right, let's go back now to the questions. Here we are. Okay, well, let's go back again to the question.
A. Excessive iliac tortuosity and acute aortic bifurcation often prohibit the placement of the internal iliac stent. Maybe.
It's not maybe, but it's not, because you have other options. If you have an acute aortic bifurcation, you can go from the arm, correct?
Yes.
So it's not completely contraindications, you know. It's not, will not prohibit it, make it more difficult, but always if it cannot, you can go through the arm, you know. And I'm going to talk about chimney later on. Go ahead, next one.
B. Branch occlusion can affect around 20% of cases.
How, when you do an iliac branch, how often the branch will occlude? Very, very few cases. Maybe like 3-4%, not 20% is too high. So usually patency is very good rate for iliac branch device. So 20% is too high. Okay. Next
Okay.
one.
C. Internal iliac sacrifice rather than performing an iliac branch endoprosthesis leads to buttock claudication around 20% of the time.
Correct, right? We just short, say 27%.
Yeah, this one is
So about
correct.
20%. Yeah. That's why I try not to sacrifice. Even in a letter, I can give you 20% claudication. Okay.
Yes. D. The most common anatomical factor that precludes IBE is the external iliac landing zone.
You see, external iliac is not a problem because it's very long, correct? The problem is the internal iliac, because internal iliac is very short and bifurcate to the anterior and lateral anterior posterior branch. So really, is the problem is the internal if they branch earlier. So really, your factor is not the external; it's very long. So you always have a plenty area to deploy it. So external iliac never been your limit. The main limit is usually the internal, because some of them are very short or bifurcate too early, so you have no space to put your stent graft. Okay. Next one.
E. Bilateral common iliac artery aneurysm are contraindicated for IBD. No, it is not contraindicated.
Okay, yes, you can do it. Okay. So again, guys, you need just to read about IFUs, you know. The other option you can do it, they did a study, they found only 30% of the patient really fit with the IFU. The majority of patients, they don't fit with the IFU because you see a lot of restrictions, the IFU and angulations, diameter of the internal, the external, the length statement, the distance of the common iliac artery, size, lengths, distance between renal artery, iliac bifurcations, a lot of IFU to get a bifurcated. The reason why only 30% of people with iliac aneurysm fit with the IFU. The reason why you have to learn how to do a chimney. Let me show you the chimney. A chimney, in my opinion, is much easier. And here you are. So chimney, you can see it here, guys. You don't have any of IFU for chimney because chimney, you make it the way you want it. So after you deploy the, and this happened before, after you deploy the EVA. You see, IBD, you do it first, then you do an EVAR. In the chimney, you do the opposite. You deploy the EVAR, then you do a chimney. So after you deploy the contralateral limb, you just from here, you put a cover stent, and you go from the arm and you put the iliac stent here. And you just put them next to each others, and you get a good seal. But to get a good seal, the first thing to see, the only IFU you have to have it is the main body has to be 1 centimeter above the iliac bifurcation. So you have a space for this to go this way. The most important, the overlap of two stents has to be at least 5 centimeters. And this way we prevent type B endoly. So if you put a short overlap here, you get a type B endoly. But if you have at least 5 centimeters of overlap, then you don't get type B endoly. Okay. And if you get type B endolic, it's not a big problem because it has no place to go. It's going to go, it will be squeezed between this area here, because here we have a seal, here we have a seal, here every place we have a seal. So blood will be just around this area, and then with the time will be thrombosed. So even if you use combination angiogram, you see type B endolic. If you get a CAT scan in a month, you think this is already gone. So this is really something you can consider. If you don't have good experience with the IBE, you can do a chimney technique.
Yes, Dr. Samer,
Any question?
which stent you will use for the extension in the external iliac?
I like to use, and that has to be a cover. It depends, you know, but it has to be a bit flexible. It's not like you use like VBX or Viaban.
Mhm.
Now we use a VBX, So of course, in the external will be self-expandable, be one of the limb. In the external will be like any external iliac, In the external we use one of the EVAR limb, but the internal I used a self-expandable or balloon expandable cover stent, and now most of the we use a VBX or viable. It depends how lengthy you want. Has to be a
But
cover stent.
is it okay to use balloon mounted covered stent in the external iliac and internal iliac?
No. In the external iliac, it has to be a self-expandable because again, we use one of the limb here. Because external iliac is very tortuous. You don't want to use balloon expandable stent in external iliac, even in the occlusive disease. Never use a balloon expandable stent in external iliac. It's very tortuous, very diseased, like an SFA. We never use a balloon expandable stent in the SFA. As I told you before, external iliac artery very equal to SFA. Very similar pathology, very similar behavior. So always use self-expandable stent in the internal is different because internal is short and straight. So you can put balloon expandable in the internal, but not external.
Mhm.
Any other
To Samer,
question?
there is another technique mentioned in the text.
Yes.
They wrote bell bottom technique.
Yes. Bell bottom technique. Yes. Bell bottom technique to use the flare limb. Like artery is 24, use like 28, called bell bottom. So the limb will be very large. But I don't advise that because you're putting, it looks nice now when you do combustion angiogram, but if you repeat the CAT scan in a couple of years, you have aneurysm. So bell bottom technique is not a good technique really, especially when you go more than 24 because they have like, Medtronic, they have 28. So if you have the iliac 24 and put like 28, you get a feel, but this will not last long, So this is not a good option. This is an option where you don't have access to the chimney, you have no access to IBE, maybe old patients. It's not the best option. You can use it, but it's not the best option. Of course, it's easier, but it's not the best option.
Mhm. Okay, thank you,
All
Dr.
right.
Samer. Thank you.
Should we stop here? I think it'll be like an hour and 10 minutes. Maybe we should stop now.
Hello, Dr. Samer.
اتفضل يحيى.
One question, please. For chimney technique, if you open iliac stent 10 millimeter, you need for both stent external and internal oversize more.
You see, the main problem was, I tell you what the main problem was the chimney. Is that you know what the external stent because you measure it, right?
Yes.
And you know the internal, correct? Because you measure it on the CAT scan, correct?
Yes.
So you know the size of the internal, you know the size of the external. But the question now, which one the main body limb is going to go, what size of the main body is going to go through these two limbs? Let me explain that to you, maybe you understand. Show you what's happening. Really, I wrote a paper about it. You can read it, guys, called How to Size Chimney. And we already published it. All right, you see the chimney now?
Yes, Dr. Samer.
Okay. The green I know it from the CAT scan. The blue I know from CAT scan. Now I need to choose the red one. This one I don't know. Because this has nothing to do with the iliac. This has to do with the size I can get good seal. So the green one, it has to be fit to the internal. So I have a fixed size. External has to fit for the external. Like if the external, like let's say 10, I use 13. If the internal iliac, like let's say 9, I use 9 balloon expandable stent. So I know the size stent here is this stent here. But now I'm going to use what the contralateral limb, because this too is going to go inside the contralateral limb of the EVAR. So now my question, what size I need to use contralateral limb? And this is a difficult, and this is what we wrote about called How to Size chimney in the iliac in the iliac aneurysm. And we came with the formula. Let me see if I can find it for you guys. I can show it to you. I don't know, I cannot find it. How to size chimney. I hope I can find it. I think I have to look for it. Here we are. And so yeah, I have it here. Okay, I'm not finding. I'll give it to you next time. Okay, I don't want to waste your time. I'll find it next time. Maybe when we start next week, we can show it to you. Any other question?
Thank you, Dr. Samer.
All
Yes,
right, guys.
Thank you.
So yes, go ahead, please. I see some question here. Let me see if I can read the question.
yeah, I have only
Yes.
two quickly here. For this last
Yes.
question related to iliac branching. So
Mhm.
when we will go for this chimney technique with both internal iliac and external iliac stenting, what's your trick to get the stent proximally at the same level? I mean, when I will deflate this external iliac stent, okay, I will go antegrade. But for retrograde, for internal iliac, I will get retrograde. So how I fix the post stent at same level in common iliac? You get my point?
Not will not be in the common iliac. They will be inside the main body of the stent.
Yes, yes.
You know, yeah, the main body inside the stent.
Yes. So
Maybe I should show you the picture. Let's see if I can find it. As I said, that was picture is much better.
Dr. Samer,
Yes.
if
Go
your
ahead.
computer contact with your WhatsApp, I will send the paper to your WhatsApp.
I have it.
Okay, I will send it now.
So I want to share it to the people so they can look at that technique and how to size it. Anyway, let me show you how you do it, guys. Maybe let's share this one. Let me see if I can share it. Share. Okay, you see now this is the technique, sandwich technique. So what happened? You deployed first the main body, then after you deployed it completely, then from below you put the. Let me make it bigger. I can see. Yeah. So what happened is that you deploy the main body, you go from the arm and you cannulate the internal iliac. So this is coming from the internal iliac and this is coming from the right groin. From the right groin, you put first cover stent, self-expandable. And from the arm, you go there down and you put balloon expandable stent. And then you just deploy them together like this way. You put them same level and you deploy them by kissing technique, you know. They always said put the internal a bit 1 centimeter above the external, but I don't like that because I'm afraid that I can't close the external, so I put them at the same level. So you can level them, you can move them up and down the way you put them. The most important, you need 5 centimeter overlap, you know. Like here, let me see. So you need at least, this is the iliac bifurcation, common iliac artery here. So you need at least 6 to 5 centimeter overlap, 1 centimeter above iliac bifurcation, 2 centimeter inside the internal iliac and 2 centimeter inside the internal iliac. So 2 by 2, and 1 centimeter above bifurcation, and at least 5 to 6 centimeter overlap between each others. This is how we do them. I'll show a couple of cases we did it, like this one. You see, they looks beautiful here. You just go, you put one here and down. This is bilateral. We did 2 chimneys here. This is also bilateral iliac aneurysm. And again, we did 2 chimneys. It looks very nice. Another patient here, aorta and iliac, and again, same with the chimneys here. You can see this is the self-expandable, this is balloon expandable stent. And this is the main body of the stent. So this is the way it works. Any questions? This is the bifurcated. The IBD is the way how you do the IBD. See, the IBD is different. You deploy first the IBD, then you put the main body. And then you put the connecting. So you deploy the IBD first, you put the main body, and then you put the connection between each other. Whereas the chimney is the opposite. This is the eye view. This is, I think, important, guys. This one for IBD. Proximal common iliac artery should be more than 17. Minimum diameter at the iliac bifurcation should be more than 14 because you have 2 stents to open. 10 iliac artery should be between 7 to 14. And sealing zone, at least you need at least 1 centimeter, 1 to 2 centimeter sealing zone. The distance from the lowest renal to the iliac bifurcation should be more than 16 centimeter, not millimeter, 16 centimeter, 166 millimeters. The angle between 10 and 10 iliac artery should be less than 50. So you see a lot of IFU when you do an iliac branch. If the patient doesn't fit his IFU, then use a chimney. Any question?
Thank you, Dr.
This is the
Samer.
bell button. This is the bell button technique. You talk about it. You see, just use a flare device. You see, narrow and wide. It's called a bell button technique. Sorry, like that. You see, but I don't like it. Most people they don't like, unless it's an old patient. But it's not good for young patient for long term. For long term patency. All right. Any other question?
For aortic balloon, Dr. Samer, for how long I
Yes.
should use?
You have to keep it as long as you need it. I mean, it's no questions. I mean, again, guys, when you rupture aneurysms, your priority keep patient alive. The worst thing, you have a beautiful, aortic repair and patient dead. So you have to keep it as long as you need it to keep the pressure control. Don't worry about ischemia. Don't worry about, because you're stopping the blood flow to the renal, or you worry about the SMA. Of course, the sooner you take it, it's better. But I will not take it earlier, but because just want to keep flow to the renal. Because once you open, you get blood pressure will go down, and this make it worse for the renal than it helps. So you need to keep it as long as possible as you want it, but try to take it down as soon, especially move from above renal to below renal, at least as soon as possible.
Okay, thanks.
Any other question? All right, guys. Thank you very much. We'll meet next week, hopefully. You take care. Bye-bye.
Thank you. Bye bye.